All right, welcome everybody to the Orthopedic Podium Session 1. I'm Jared Kaiser. I'm an instructor at Emory University. I'm joined by my two co-moderators who will introduce themselves.
Hi, I'm Amy Lenz. I'm a research faculty at the University of Utah in Orthopaedics.
And I'm Stephanie Koehn, and I'm a postdoc at the University of Wisconsin in Madison.
This session will be formatted the same as most of the other podium sessions that you've already attended. There will be 12 talks broken into 3 half-hour blocks. Each half-hour block will consist of 4 or 5-minute lightning talks, followed by an 8-minute question and answer session. To accommodate as many questions as possible, we ask that you make sure you are logged in using your real name, request that you type your questions into the chat box, and address to whom you're asking the question. We'll be monitoring the chat window and reading the questions that come in during the question and answer period. Please note that this session is being recorded and will be posted on the conference site shortly after it is complete. We invite you all to participate in a continued discussion of these presentations in the dedicated Slack discussion channel associated with this podium session. You can find this on the ASB2020 Slack website. We also invite you to have follow-up face-to-face discussions with each other in the virtual ASB lounge, which is available on the schedule as the ASB Spatial Chat Hangout and Session Room. We'll be in the Qualisys Lounge location 4, and we'll post that link towards the end of the session. So our first talker today is Ben Binder-Markey, presenting Whole Muscle Passive Mechanics Do Not Simply Scale by Architectural Properties.
Actually, that was my last talk. This talk will actually be dense intramuscular connective tissue drives collagen content within variation within muscles. I'd like to thank everyone for taking the time to listen to our work, and I'd like to thank my co-authors for their contribution to this work. So collagen is thought to be the primary load-bearing component within passive muscle, and therefore likely responsible for the passive mechanics of the muscle as a whole. However, as demonstrated in the graph on the right, the stiffness of isolated muscle bundles is not correlated with the collagen content of those bundles as measured by a hydroxyproline assay. This weak or non-existent correlation between muscle collagen content and passive stiffness has been found in both human and rodent muscles. This may be because isolated bundle preparations are unable to take into account the impact of the muscle's intramuscular anatomy, that is the distribution of the stiff connective tissue and compliant muscle tissue on the collagen content throughout a muscle, such that using a single collagen content value may not adequately represent the tissue's load-bearing capacity. Therefore, the purpose of this study was to determine how a muscle's intramuscular connective tissue structures impacts collagen content. We have previously shown that within 3 muscles of varying action and anatomy from the hind limb of the mouse, the rectus femoris, the semimembranosus, and the tibialis anterior, that the collagen content of these muscles varies significantly within and among muscles. This collagen content varies systematically throughout the muscles with higher values at the proximal and distal ends, with lower content in the middle. At the ends, you have intramuscular tendons and aponeuroses present, and this leads us to believe that the variations within muscles are really being driven by these connective tissue structures. And if these structures are present, we should be able to visualize them. To visualize the structures, we took histological sections throughout the length of the muscle and stained the connective tissue red using a picoseries red. The dense connective tissue structures were then traced and quantified. Here we have the internal tendon in dark blue and the external tendon or external aponeurosis in green. The sum of these areas over the total area of the muscle of each section gives the area fraction occupied by these dense connective tissue structures within each section. These plots show the average area fraction of dense connective tissue with 1 standard error along the length of each of the 3 muscles. Increases at the proximal and distal ends are again present as they were with the collagen content measurements. So if there is a relationship between the collagen content and area fraction of the dense connective tissue, plotting the two together should demonstrate any relationship if present. So on the left, we have the collagen content from the rectus femoris that was previously shown, and we can plot that collagen content versus the summed area fraction, which is the area fraction summed over consecutive histological sections, representing the volume fraction of the connective tissue in those samples. Now adding the remaining muscles and conducting a linear regression analysis across the data points, we find a strong correlation. suggesting that collagen content is being driven by the internal architecture of these dense connective tissue structures. To further corroborate this relationship, we approached this problem using two additional independent analyses. The first was to create a law of mixtures model. So at the top, if the collagen content is really being driven by the connective tissue structures of internal tendons and aponeuroses, we should be able to predict the total collagen content from the volume fraction of those dense connective tissue structures by knowing the collagen content of pure tendon and muscle that we have previously collected and the density of each. This relationship between the summed area fraction and collagen content is demonstrated by the black line, and the shaded region is the range of values as predicted within one standard deviation within the range of those pure muscle and tendon values that we previously collected. We observed that the previously plotted values fall along this predicted relationship and within this predicted range of values. The second approach was again using this law of mixture model, but now solving for the collagen content of pure muscle and tendon using a nonlinear optimization and the previously plotted points. So here we have those optimized values, and when plotted in the gray dotted line, the relationship lies along the linear regression analysis, but at higher area fractions, these two do diverge. To ensure we weren't missing the contributions of loose connective tissue structures that include the endomysium, the paramysium, and any connective tissue structures that are surrounding the neurovascular tracts, we added the area fraction of these structures into this same linear regression model, as well as the optimization model. And the addition of the loose connective tissue did not improve the fits, and the predicted collagen content was negligible for these loose connective tissue structures, indicating that they don't contribute to the collagen content variation between and among muscles. So in conclusion, we demonstrated that collagen content varied widely within and among muscles, and we found complementary and corroborating evidence suggesting that this variation in collagen content is driven by the dense connective tissue structures within muscle, and that the loose connective tissue structures do not contribute to this variation. A consequence of these findings suggests that a single collagen content measurement does not accurately represent a muscle's connective tissue geometry and potentially the load-bearing capacity of that muscle. So thank you for your time, and thank you for our funding sources.
Great, thanks, Ben. Next up, we have Lomas Persad presenting in vivo measurement of gracilis muscle tendon characteristics.
Thank you for that introduction. Hello, everyone. My name is Lomas Persad, and today I'll be sharing our work on how we measure in vivo gracilis muscle tendon parameters. Also, I'll be looking at how experimental MTU lengths compare with those predicted using musculoskeletal models. Musculoskeletal models are being used across various research fields to answer questions involving human locomotion. And in particular, they are being applied in scenarios where performing practical experiments are not feasible. To drive acceptance and broaden the impact of these models, there must be validation. The aim of the study was to measure in vivo gracilis muscle tendon parameters. This included muscle tendon unit lengths, muscle architectural data, and isometric force length data. Then these MTU lengths that were measured experimentally were compared with those predicted using OpenSim. And this highlights, or this represents the focus of this talk today, where we will look at how experimental MTU lengths compare with those predicted using OpenSim for each individual, and errors are presented as such. 4 OpenSim models were chosen, and they were scaled linearly according to subject-specific segment lengths. Data were measured from 15 subjects who were all undergoing a muscle transfer surgery. MTU force and lengths were measured intraoperatively at 4 joint configurations, shown in the table and figure here. Muscle tendon force was measured using a buccal force transducer secured to the external tendon of the gracilis, while the muscle itself was stimulated at 2 Hz and 20 Hz, and at 50% and 25% of its maximal CMAP current. And these parameters were chosen as it represented a good compromise between inducing tetany in the muscle and also controlling the large forces being produced during surgery. While the muscle was, after the muscle was harvested, it was captured using, it was recorded using photography and also weighed. Also using videos of the muscle, 3D models were created using open source photogrammetry software. While all this layouts represents or highlights the data being measured intraoperatively, as I mentioned previously, the focus today will be looking at the MTU lengths. The graph on the right summarizes experimental MTU lengths and force data, where we have MTU lengths ranging from 42 to 52.8 centimeters across joint configurations. It was observed that as the muscle lengthens, the force increases and also then decreases, where the maximum force occurred at that third joint configuration or MTU length of 49 centimeters. A summary of other muscular tendon parameters are presented in this next table, where particularly to note, muscle PCSA was found to be 3 to 4 times greater than what is reported for cadaveric data, and highlights the importance of in vivo data, capturing in vivo data. Now looking at that comparison between experimental data versus model data for MTU lengths. Firstly, it was observed that models generally underestimated MTU length, especially at that first joint configuration, after which they then began to overestimate, where predictions got worse the longer the MTU length. A maximum individual error was recorded as 30%, and the absolute mean error across all models were between 5 and 11%. Now looking at the muscle length themselves, it was observed that this was dependent on the external tendon length used in the model, where models 1 and 3 had a much longer tendon length compared to the other 2 models and also compared to the experimental data. And as a result of this, they underestimated muscle length, particularly at joint configuration 1, where individual errors you can see exceeds 40%. Now overall, looking at all these errors, it was found that model 2 was the best performing or the best model. So in summary, in vivo gracilis muscle tendon parameters were captured intraoperatively. This included MTU lengths, where individual MTU length errors of up to 30% needs further investigation in the context of force generation. I'd like to thank the Department of Veteran Affairs for funding this project, as well as my colleagues at Mayo Clinic and the Shirley Ryan Ability Lab. Thank you.
Great, thank you, Lomas. Next up, we have Kristen Jakubowski. She will be talking on the muscle stiffness exceeds tendon stiffness at physiologically relevant levels of muscle activation.
Hello, my name is Kristen Jakubowski, and today I'll be discussing our recent finding that muscle stiffness exceeds tendon stiffness at physiologically relevant ranges of muscle activation. The ability to successfully navigate our environment, such as adapting to uneven terrain or resisting postural disturbances, requires the appropriate regulation of joint mechanical properties. When focusing on the ankle impedance, illustrated graphically as the spiral, depends strongly on the mechanical properties of the muscle tendon unit spanning the joint, as well as the degree to which the muscles are activated. It's also well known that the force-reducing capabilities of the muscle are dependent upon the mechanical properties of the tendon. So the tendon can influence not only the joint, but also influences the behavior of the muscle. And while ankle impedance has been well characterized, it's currently not possible to quantify the individual contributions for the muscles and tendons spanning the joint, nor is it possible to simultaneously quantify the muscle and tendon. These two limitations present a critical gap, as the muscle and tendon can be selectively altered by aging, pathology, or injury. Additionally, the inability to simultaneously assess both the muscle and tendon inhibits our current understanding of the interaction between the two. So understanding how the muscle and tendon contribute to the impedance of the ankle over a range of activation levels will provide a clear understanding of their respective roles in the unimpaired and impaired control of posture and movement. We recently developed a novel technique to simultaneously quantify ankle, muscle, and tendon impedance. And using this technique, we sought to quantify the relative contributions of the muscle and tendon to the impedance of the ankle over a physiologically relevant range of plantar flexion torques. Our technique combines joint level measurements with ultrasound images of the muscle tendon junction. We use a non-parametric system identification analysis to then quantify ankle, muscle, and tendon impedance. And we collected data in 4 young adults, and the experimental setup can be shown here in the lower left-hand corner. This cartoon is conceptualized how we differentiated between the impedance of the muscle and tendon. So we modeled the muscle and tendon as two impedances in series connecting at the muscle-tendon junction, which is shown as the red dot. And here's an example of the collected ultrasound image, again with the muscle-tendon junction highlighted by that red dot. We're rigidly manipulating the ankle joint, which results in displacements of the muscle-tendon junction, which can be seen here. Since the proximal end is fixed by stabilizing the knee, by imaging the connecting point between these two impedances and quantifying the resultant displacements from the changes in ankle angle, we can then decouple the two. So going into the results, I'll be showing the stiffness or the static component of impedance, and I'll be showing muscle and tendon stiffness as a function of muscular tendon force for the 4 young adults that we collected. So first, plotting tendon stiffness, the solid line is representing a fitted model with the shaded region being the 95% confidence intervals. We can see that as the muscular tendon force increased, tendon stiffness increased. And this increase in tendon stiffness is due to the nonlinear mechanical properties of the tendon and indicates that we're likely operating on the nonlinear total region of the tendon stress strain curve. When I add in the muscle stiffness, we see that again, as force increased, muscle stiffness increased. However, the stiffness of the muscle increased faster than that of the tendon, with muscle stiffness exceeding tendon stiffness at about 100 newtons, which was roughly about 7% of the maximum voluntary contraction for our subjects. So there's a couple of key conclusions from this. First, as I mentioned, we're likely operating on the nonlinear toe region of the tendon stress strain curve. Second, we demonstrate that the Achilles tendon is less stiff than the muscle over most of the tested range. Since the mechanics of the ankle are going to be constrained by the more compliant component, this implies that ankle mechanics are governed by the Achilles tendon over nearly the entire range of physiological activations. This also means that the torque-dependent increase in ankle stiffness that's normally attributed to the muscle is actually due to the nonlinear properties of the tendon. Ultimately, these findings are not only useful for understanding the unimpaired control of posture and movement, but our technique may also be useful for tracking mechanisms contributing to altered ankle mechanics that occur with aging, injury, or pathology. Thank you for listening, and I can answer any questions.
Great, thank you, Kristen. Next, we have Josh Pataky speaking on the effect of rotator cuff tear severity on joint loading during dynamic tasks.
So hello everyone, my name is Josh Pataky. The work that I'm presenting to you today examines the effect of rotator cuff tear severity on joint loading during dynamic tasks. So rotator cuffs are common in older adults, with tear severity ranging from a partial thickness tear of the supraspinatus to massive 3 tendon tears that include tendons of the supraspinatus, infraspinatus, and subscapularis muscles. Previous studies have observed that with increased tear severity, glenohumeral joint contact force, which is the force of the humerus on the glenoid fossa of the scapula, is relatively consistent for static postures, but those joint contact forces change across static postures, suggesting that during the performance of dynamic tasks, the joint contact force magnitude and orientation may also change, and these changes could exacerbate the cuff tear or lead to the development of a secondary injury. However, it is unclear how joint contact force magnitude and orientation change with dynamic task performance. Therefore, our objective in the study was to determine how glenohumeral joint contact force changes with increased rotator cuff tear severity during the performance of 3 dynamic tasks. A computational musculoskeletal model of the upper limb was developed in OpenSim to represent mean muscle force generating characteristics of healthy older adult males. The model was then modified to represent 8 different rotator cuff tear severities by systematically reducing the peak isometric force of the supraspinatus, infraspinatus, and subscapularis muscle pads. A baseline model was created to observe the healthy rotator cuff, in which each of the 4 cuff muscles were at 100% of their peak isometric force. A partial thickness tear of the supraspinatus tendon was modeled next by reducing the supraspinatus muscle force to 50%, with the rest of the muscle forces kept at 100% of their peak isometric force value. This was continued through for massive tears, including the supraspinatus, infraspinatus, and subscapularis muscles. Kinematics for 3 dynamic tasks representing typical daily tasks were measured experimentally from 4 healthy older adult males in a prior study. All motions have the same beginning and ending point, which will be noted as 0 and 100%, with the halfway point of each motion noted as 50%. The first motion was a forward reach, with the person's arm starting at their side, reaching out, and then returning. The second dynamic task was a functional pull, which was a reciprocal of the forward reach task. And then the final motion was an axilla wash, where the arm started at the person's side, was brought across the body to touch their shoulder, and again returned. With the models and the dynamic task kinematics, a series of computational simulations were performed using OpenSim's computed muscle control and joint force analysis tools. All permutations of participant task kinematics and tear severity models were run for a total of 96 simulations. The peak resultant joint contact force for each simulation was then identified and averaged for each tear severity and compared to the no rotator cuff tear model. So first, we'll observe the orientation of the peak joint contact force for the forward reach motion when projected onto the glenoid. To briefly orient you to these graphs, the ellipse is a representation of the glenoid rim, and the dot within the ellipse is the orientation of the peak joint contact force for the no cuff tear model. It's slightly in the posterior superior quadrant, but well within the glenoid rim. As tear severity increases, noted by each of the plus symbols, the joint contact force moves more posterior and superior, but still remains well within the glenoid fossa. And the same trend is seen when observing both the functional pull and axilla wash motions. As tear severity increases, there is a posterior superior translation of the joint contact force orientation, though it always remains within the glenoid rim. So next, we'll take a look at the magnitude of the peak joint contact force for each tear severity, again compared to the no rotator cuff tear model. The forward reach motion is shown in blue, functional pull in orange, and axilla wash in gray. Little difference is seen for partial or full supraspinatus tears when the peak joint contact force is compared to the no cuff tear model. However, when the tear extends to include the infraspinatus tendon, we see a significant decrease in joint contact force with the functional pull and axilla wash tasks. This significance is maintained when tear severity increases to involve the subscapularis tendon, with the trend plateauing once the most severe tear severities are reached. And despite the different motions across these tasks, we're seeing the same trend for all three of these dynamic tasks. So in this work, we found that when tear severity increases, the projected location of the peak joint contact force orientation trends superiorly in the glenoid, while the magnitude of this force decreases for the increased tear severities. These observed changes are consistent across all the dynamic tasks, and this decreased trend that plateaus with severe tear severities provides insights into the types of joint loading changes that can be anticipated with increased tear severity during dynamic task performance. These descriptions of changes to joint contact force loading may also be helpful in identifying possible thresholds where shoulder function begins to decline. Ongoing work looks to observe other dynamic tasks that have diverse postures from those used here, such as a hair comb or a reach behind the back. And we also seek to explore the predicted muscle activation patterns to examine any compensatory roles of uninvolved muscles in the shoulder and how their contribution changes with increased rotator cuff tear severity. With that, I'd like to thank the funding sources that made this research possible, including ASB for the 2020 Student Travel Award and my lab mates for all their assistance. And finally, I'd like to thank you for your time and attention. I look forward to discussing this work further in the Q&A period.
Thank you, everyone, for these great presentations in this first block of our session. I'll now start with questions that were posed from the chat window. So thank you, everyone who made comments in the chat window. We'll start for Ben, a question from Stephanie Koehn. She said, that was very interesting. I am wondering how sensitive these results may be to specimen age and loading history, since the specific collagen types could vary by tissue composition.
Yeah, thank you, Stephanie. I think it's actually, I'm going to combine this in somewhat to Amy's question prior to that about cerebral palsy and also post-stroke. I think these methods are going to be actually very sensitive to the specific specimen because, or the species, age, because the collagen content, as you were saying, is going to change, but it's mostly still going to be type 1 and type 3 collagen within that. But to give you a sense, within the mouse muscle, the pure muscle tissue is about 3 micrograms per milligram. We actually had some human tissue that we measured on, and the pure muscle was actually 3 times that, was almost up towards 10 micrograms per milligram, so a little bit more than 3 times. So it is going to be the variables or the parameters within the models are going to be subject specific, or I guess specimen age specific and loading history specific, but the methods are still going to be the same. So you can use those same methods, you're just going to have to plug in different variables or different parameters.
Perfect, thank you. We'll now field a question for Lomas from Don Anderson. He said, interesting findings and thanks for sharing. I'm a bit confused about how you flag differences between your observations and the distributions reported in the literature. Couldn't your findings just be explained by your specimens being from the edge of those within prior study populations?
Okay, thank you for the question. I think I just need to clarify the distributions that you saw in my presentation. They were predictions made by OpenSim models. So they were not quoted as literature or taken from literature. So it's a pure experimental versus prediction by a model. So that's a distinction there.
Great, thank you. Our next question is for Kristen from Rick Lieber. Is it surprising that tendon stiffness is linear with force?
It was slightly surprising. I've collected data in more subjects that have a higher range of force, and we do see more of a curvilinear relationship, especially at higher forces, suggesting that we may be getting to the linear region of the tendon stress strain curve.
Excellent, thank you. Our next question is for Joshua from Clarissa Leivasura. Sorry if I didn't pronounce that right. Thanks for your presentation. Were the kinematics recorded from healthy individuals or those with rotator cuff tears? Do you think this would make a difference? That is, do you think the kinematics would have changed between the two groups, altering your results?
Yeah, so the 4 patients' kinematics that were used for the data here were from healthy patients. And I do think that if we look we plan to in the future look at kinematics recorded from patients who have rotator cuff tears as well. And I do expect there to be a difference between the two, though we have not generated any data to see how much of a difference there could be.
Excellent, thanks. Does anyone else have another question for Ben? He combined the 2 previous ones. So if not, I may jump to another question from for Lomas from Jared. He says, nice talk. Can you comment on if you think there might be a systematic over or underestimation of muscle parameters by which we could predict correct values for muscles other than the gracilis? Or do you predict that we'll need to repeat this study on more muscles?
Okay, so it would be difficult to comment if there's a systematic over or underestimation based on just looking at MTU lengths, because as we would know, MTU lengths is mainly driven by the scaling used by the models. So it would be difficult to say that, and also to the point of predicting if it's easy to extrapolate data from just studying one muscle. I would think because of how muscles function across the joint, it'd be better to actually study muscles individually because of how they function differently.
Great, thank you. Our next question is for Kristen from Greg Sawicki. He said, awesome and creative experimental setup to get critically important data. Any plans to extend this to overground locomotion, similar to experiments by Roos et al., but with the ultrasound going?
We're not planning on directly coupling it with some of Elliot Rouse's work. We have in our lab done a dynamic cyclical contractions, and we do plan on coupling these measurements with those to get concentric, eccentric, and static data.
Excellent, thank you. Our next question is for Joshua from Rick Lieber. There is evidence that muscle and connective tissue properties change with tears. Was this included in your model?
That specifically is not included. The way that we the way that we altered the model was by altering the force generating capabilities of each of the muscles, by systematically reducing each of those to produce increasing tear severities.
Excellent, thank you. I think that'll conclude our Q&A unless anyone else has more for this session. I'd always like to remind you that you can post in the Slack. We have a dedicated channel for this podium session. And so if there are more questions following each block, you can pose those questions in Slack.
Great. Moving on, we have Sabreen Megherhi speaking on the effects of osteoarthritis in unicompartmental knee arthroplasty on hip, knee, and ankle joint kinematics.
Thank you for having me. I'd like to begin by acknowledging the contributions of my co-authors. This study investigates the effects of osteoarthritis and unicompartmental knee arthroplasty on hip, knee, and ankle joint kinematics. These are our disclosures. In 2014, there were approximately 600,000 total knee arthroplasties performed in the United States. They are most commonly performed due to end-stage osteoarthritis. If a patient has OA confined to the medial or lateral portion of their tibiofemoral joint, a unicompartmental knee arthroplasty can be a viable alternative. UKAs are associated with lower postoperative pain and faster rehabilitation times. Previous studies have investigated lower body joint kinematics in patients that received TKAs, and they have reported some changes in joint moments, but not joint kinematics at the hip, knee, and ankle. In contrast, there's a lack of research regarding patients that receive UKAs and joint kinematics pre and post-surgery. The purpose of this study was to compare side-to-side differences in hip, knee, and ankle joint kinematics during walking, both pre and post-surgery in patients receiving a UKA. Our hypothesis states that preoperative side-to-side differences in hip, knee, and ankle kinematics would be resolved after a UKA. 9 patients with an average age of 62 scheduled to receive a medial UKA consented to participate in this IRB-approved study. They each completed pre-surgical and post-surgical testing. We used a custom set of 45 reflective markers based on anatomical positions from visual 3D recommendations and custom tracking markers as shown here. All patients then walked across a 7-meter lab walkway at their self-selected pace for at least 6 separate trials, while a 12-camera Vicon motion capture system collected data at 100 Hertz. An average of 9 steps were included per person per leg each day. Bilateral hip, knee, and ankle flexion extension and ab adduction were then normalized to percent gait cycle and averaged across all trials, as shown in this graph. Average joint kinematics were then calculated for each leg pre and post-surgery. Statistical parametric mapping was then used to compare kinematic curves of the UKA and contralateral limbs using a 2-tailed pair t-test with significance set at p less than 0.05. This figure shows the ankle, knee, and hip sagittal plane joint kinematics throughout the gait cycle pre and post-surgery. We were unable to identify any significant side-to-side differences in sagittal plane kinematics before and after surgery. This figure demonstrates the ankle, knee, and hip frontal plane joint kinematics throughout the gait cycle pre and post-surgery. Although we found no significant side-to-side differences in frontal plane kinematics before and after surgery, these results do show trends towards the restoration of knee frontal plane kinematics that were accompanied by greater side-to-side differences in ankle kinematics post-surgery. The results of this study suggest that kinematic differences at the hip, knee, and ankle in the sagittal and frontal plane are small prior to and after UKA. Our inability to find any differences between knees or changes from pre to post surgery may be due to skin motion artifacts associated with conventional motion capture. These results agree with a previous study that found no changes in ankle, knee, and hip kinematics from pre to post TKA. Additionally, UKA may restore native knee kinematics. However, larger studies are needed to investigate the effects of UKA on ankle and hip kinematics and kinetics. The next steps for this study include processing the data of different activities, including chair rises and stair ascent. Here's an example of a patient completing a chair rise. Previous studies have shown that these activities are more difficult for patients before knee replacement. Additionally, in the future, we would like to compare hip, knee, and ankle joint kinematics of patients who have received UKA versus patients that received a TKA. Thank you for your attention, and I encourage you to visit our lab website to learn more about our research.
Great, thank you, Sabreen. Next, we on the modular control and patient function in individuals with knee osteoarthritis and total knee arthroplasty. Rebekah, you're muted right now.
Thank you. Thanks for the introduction. Can you see the right side of my PowerPoint here? Yes, okay, great. Okay, thanks so much. So yes, I'm Rebekah Koehn. For those of you who attended my 3-minute thesis talk yesterday, you'll remember who this is, but if not, meet Molly. Molly recently developed knee osteoarthritis, which prevents her from kneeling in her garden. She'll soon undergo a total knee arthroplasty, which is the end-stage treatment for knee osteoarthritis, with over 1 million surgeries expected annually by 2030. While TKA improves patient function and reduces pain, more than 20% of adults still have functional deficits 2 years post-surgery. Several studies have investigated whether these deficits are influenced by the preoperative condition or factors in the operating room, but we have yet to find a primary factor that can reliably predict patient outcomes. One promising area of research is neuromuscular control. However, previous work has focused on individual EMG waveforms, which alone cannot provide insight into the overall control strategy and its influence on patient function. One way to study control strategy is with the theory of modular muscle control. Rather than being activated individually, this theory describes how groups of muscles are activated synergistically by common neural commands, which give insight into the underlying control strategy. One recent study reported that high and low functioning TKA patients demonstrated different modular control at 1 year following a cruciate retaining TKA. These results indicate that neural control may be an underlying mechanism which explains the observed ranges in function in this population, but the open question remains, does this relationship hold true with other implant designs and through the time course of recovery? So the purpose of our study was to determine the relationship between patient function and modular control before and after TKA. We hypothesized that patients with better function would have more modules and that those modules would resemble healthy age-matched controls. 36 individuals underwent a primary TKA and were tested in our motion analysis laboratory before and after surgery. The same individuals returned at the 6 and 24-month time points after surgery. We collected motion capture using the modified full body point cluster technique and collected EMG on 8 lower extremity muscles bilaterally. We also collected data on several functional tests, but I'll only be reporting on the 6-minute walk test today. We extracted modules from the EMG of 1 gait cycle for each participant, and here I'll use the biceps femoris muscle in an example where the participant had 3 modules, each active during a different part of the gait cycle. All 8 muscles were weighted within these modules, and we can see the weight of the biceps femoris darkened in each module. By multiplying the muscle weights by their respective activation profiles and summing the module contributions, we can reconstruct a waveform for the biceps femoris which closely matches the original EMG. We perform this process using non-negative matrix factorization, where an initial guess for the muscle weights and activation profiles are multiplied to reconstruct the EMG. This process is iterated until the error between the reconstructions and the experimental EMG falls below a certain threshold. And this tells us 3 things about the individual's control strategy: the number of modules used to reconstruct the EMG, the muscle weights, and the timing profiles of each module. This presentation will focus on those first 2. We found that participants demonstrated between 2 and 4 modules at each time point. Those who showed 2 modules had a plantar flexors module and a merged quadriceps and hamstrings module. Those with 3 had distinct quadriceps and hamstrings modules, and those with 4 demonstrated additional separation of the rectus femoris or the soleus muscle. Contrary to our first hypothesis, we did not find that the number of modules was related to 6-minute walk performance before or after surgery. To test our second hypothesis, we examined the muscle weights in participants with 3 modules dominated by the quadriceps, plantar flexors, and hamstrings. We separated the participants into high and low functioning groups based on 6-minute walk performance, and we adapted a procedure from Hayes et al. To determine and count which muscles were significantly active in each module. In the interest of time, I'll highlight just the plantar flexors module, which we compared to the same module from a healthy age-matched group. Preoperatively, we saw that the high-functioning group organized this module exactly like the healthy group and demonstrated plasticity and control throughout recovery, whereas the low-functioning group had fewer active modules preoperatively and kept the same organization throughout recovery. So although we did not find an association between higher number of modules and better patient function, there may be a relationship between module weights and function. The observed changes in modular control in the same individuals tested at multiple time points is a new finding in this orthopedic population. And although we were limited in the number of gait cycles we could evaluate, this work may open opportunities for new rehabilitation protocols to improve patient function. We thank our sponsors, and if you would like to learn more about Molly, you can follow this link to the YouTube video. Thank you.
Great, thank you, Rebekah. Next, we have Sabreen Megherhi speaking on the effects of age-related changes on fracture resistance of human cortical bone.
Hi, everybody. I'm going to talk about the effects of age-related changes on fracture resistance of human cortical bone. I'm doing my PhD at the MCMB lab directed by Dr. Ahmad Najafi. And also I have my colleagues Timothy Josephson and also Jason Moore. This work has been done at Drexel University at the Department of Mechanical Engineering and Mechanics in Philadelphia. So the motivation of this work is to capture crack growth in human cortical bone in different regions. So to do so, we actually did the cutting samples from the whole bone in tibia for 2 different ages, 60 and also 81. And then we, for our simulations, we did cutting in the cortical bone sample in the anterior section and also medial and lateral and posterior. So here I also talk about only the anterior region in this spot. So after some image processing, we got the microstructural features here, such as interstitial bone, osteons, hair canals, and cement line. And also we perform a staining technique to capture clearly as possible to capture the cement lines. So here, after some image processing, we found that we are seeing a great difference in hair canals from 60 to 81-year-old samples. And also we are seeing higher average area of single osteon in 60-year-old tibia. And also we are seeing high osteal density in 81-year-old models. To do the crack growth simulations, we need to have the elastic modulus and also the toughness or critical energy release rate of the features such as osteon, interstitial tissue, cement lines. So here we assume that osteon is tougher than the interstitial bone, and also interstitial bone is stiffer than the osteons for 60-year-old model. However, for 81-year-old model, we consider 50 decrease in toughness and 10% decrease in the stiffness. In this basic here, we are using a brittle framework of phase field method to capture the crack growth analysis. So here we consider a plane strain condition, and this is our simulation basis here. Here we have a pre-crack, and also we apply a tensile loading on our models. After applying the load, we are seeing the full crack propagation in the models. So here you can see that crack started from the pre-crack over there, and we are seeing high stress concentration in the Haversian canal. So crack propagates directly in the osteons, and then gonna be arrested in the cement lines, and another crack started from the Haversian canal in this specific model. So here we are seeing that crack branching as one of our first toughening mechanism here, and also crack is arrested in the cement lines, and we are seeing crack bridging here, and also micro cracking in the Haversian canal, and also we are seeing crack deflection. However, in 81-year-old model, we are seeing some different crack propagation. Here, because of this Haversian canal, which has an abnormal feature, the crack started from this spot, and simultaneously another crack started from other side of the void. So the crack propagates through the cement line, and the stress is released. Here also we are seeing the crack is arrested in the cement line, macro cracking in Haversian canal, and also crack branching in the cement line part here. So by looking at the result from the force displacement curves here, we are seeing the decrease in the stiffness as we expected, and also the whole toughness, the area on the curve. But for the 60 model, we are seeing a brittle behavior here, and the crack propagates very fast through the model. However, after the yielding point for 81-year-old model, we are seeing some resistance, and those resistance are because of those toughening mechanisms, especially because of the crack arrest in the cement line. So the post-yielding behavior would be different for these two models. So in conclusion, we are seeing that the toughness is decreased by age, and also post-yielding behavior is highly dependent on the age. And we are seeing these microstructural features such as distribution of osteons, osteal density, the area of Haversian canals, the mechanical properties of those cement lines, and osteons and interstitial would affect our crack growth trajectory. And here it's worth to mention that the phase field method here is a powerful method to capture various toughening mechanisms such as crack deflection, crack bridging, micro cracking, crack branching, and also crack arrest in the cement line. So at the end, I thank my colleagues at the MCM lab at Drexel and also Bone Biomechanics lab at the University of Massachusetts, Dartmouth, Dr. Karim, and also Taran Rezai, and also Dr. Teresa Freeman at Thomas Jefferson University. Thank you so much.
Great, thank you, Ibrahim. Next, we have Mir Barak. He was not able to make it online today due to a power outage associated with a hurricane. However, we have a video of his talk on trabecular bone stiffness and yield are not declined after exposure to Staphylococcus aureus.
Good afternoon. My name is Mir Barak, and I'm an associate professor at the School of Veterinary Medicine at Long Island University, New York. Today, I'll present to you a research project done in collaboration with Dr. Victoria Frost and Emily Long, both from the biology department at Winthrop University, South Carolina. The title of my talk is Trabecular Bone Stiffness and Yield Are Not Declined After Exposure to Staphylococcus aureus. So bone infection, osteomyelitis, due to Staph aureus is a growing problem, which is challenging to treat due to the difficulty of early diagnosis and growing antibiotic resistance. The susceptibility of trabecular bone to osteomyelitis is potentially higher compared to cortical bone due to the tissue high porosity and increased surface area, which increase the bone bacteria interface and at the same time lessen the effectiveness of antibiotic treatment. This in turn may have long-term negative effect on bone stiffness and yield, which is an important information when we use allogenic bone graft from bone banks in patients. So the working hypothesis of our research was that trabecular bone exposed to Staph aureus for 72 hours would demonstrate a significant decrease in structural stiffness and yield compared to a control group that was exposed only to sterile nutrient broth. To test our hypotheses, we used 103 trabecular bone cubes harvested from the proximal tibia of 9 white-tailed deer. And in this figure here, you can see the location of the proximal tibia where the slices were taken and the procedure of how the cube were cut and created. Bone cube were incubated in either sterile broth or nutrient broth inoculated with Staph aureus. After 72 hours, all cubes were tested in compression along the axial direction, and structural stiffness and yield were calculated. As expected, we found a significant positive correlation between stiffness and yield for each group and for the pooled data, as can be seen in this figure. Yield here on the left in the y-axis and stiffness on the x-axis. However, we did not find any significant difference between the two groups for both stiffness here on the left and yield here on the right. And thus, these results refute our working hypothesis. The axial direction, which is the direction that we tested our cubes on, corresponds to the primary physiological direction of loading of the proximal tibia that would occur during normal activities such as walking, running, or jumping. Thus, these results indicate that exposure to Staph aureus probably does not adversely affect trabecular bone stiffness and yield during daily loading activities. According to current FDA guidelines, eligible bone donors must not have had a diagnosis of sepsis immediately preceding death. But there is no mention of previous osteomyelitis diagnosis as a donor restriction. So in conclusion, our results and our findings support the current tissue collection screening methods employed by bone graft banks. Thank you very much.
Excellent. That was a great session of a lot of wonderful talks. We'll jump into the Q&A session, and I encourage people to continue including their comments and questions in the chat window. So first, we have questions for Sabreen. And the first one we have says, did you measure ground reaction forces? If so, did you have data on joint moments of these patients? Nice study.
So we did measure ground reaction forces. However, we have not done any analysis of it yet. That is to be the next step of the study, which would be interesting to look at, especially given that some previous studies did find differences in joint moments of patients that received TKAs. So.
Excellent, thank you. Our next question is for Rebekah from Josh Roth. Nice talk. Were there any intraoperative differences between these groups? Laxity alignment, for example, that might have caused some, but not all patients to alter their neuromuscular control post-operatively?
This is a really great question. And I like this intraoperative question. We haven't run those tests yet, but we do have laxity information, intraoperative information for these patients. So that'll be something to consider looking at next.
Excellent, thank you. Next question is for Ibrahim. For me, I said, fascinating work. Did you consider your damage propagation results and how it could correlate with bone density that could be extracted from medical imaging to apply modeling to in vivo imaging techniques?
Actually, yeah, we consider, we did, image processing to capture porosity, for example, such as lacunae and hydroshot canals, but not in these models that you are seeing here. You don't see any, porosities over there, but for sure, yes, as we have lacunae, we change the crack propagation path, and also it would change the toughness.
Excellent, thank you.
Welcome.
Next question for Sabreen from Fran Sheehan. With your variability at the knee, I'm curious about your stats. Were you comparing group averages or was this a paired analysis?
So this was a paired analysis, so we were looking at changes within subjects over the entire gait cycle.
Excellent. And to add into that, for those that may not be familiar with statistical parametric mapping, can you expand on why you used SPM for this dynamic analysis statistically?
So this, I personally don't have a ton of experience in SPM. This was done by another person in my lab, so unfortunately I can't answer your question, but I could, if we move this over to Slack, get some more information and give you that answer.
Perfect, thank you. We'll discuss that in Slack. The next question we have for Ibrahim, very interesting work. What type of material model did you use for the FE model in your study? Were there transversely isotropic models, orthotropic models, etc.?
All of the material properties that we used was homogeneous and also isotropy.
Perfect, thank you. All right, let's see.
There's a question for Rebekah as well. Did you look into potential relationships between the number of modules and population characteristics within your subjects, like age or level of activity? Have you looked into the length and type of rehab activities needed to retrain these muscle modules?
Yes, another great question. So to answer the first one, we did look into population characteristics and the number of modules. We didn't find a relationship here, except for maybe with the height of the participants, but in terms of age, sex, BMI, or walking speed, we didn't see any associations here. To answer the second question, we didn't track rehabilitation in this study, but that's something we're definitely looking into for future work.
Perfect, thank you. Here's another question for Sabreen. Great talk, 2 questions. 1, did you compare the changes in joint kinematics within subjects or just the overall joint kinematics patterns between pre-post surgery? And 2, well, actually, I'll let you finish that one first, and then I'll go on to 2.
Okay, so we did do side-to-side differences to see how they would compare pre to post surgery, but we didn't do day-to-day differences to see if they were different between legs, if that clears that up.
Perfect. And part 2 of this question is, soft tissue artifact is a major issue for motion capture studies. Do you have any plan to use biplane video radiography techniques to look at the actual knee joint motion? Great talk, thank you.
So yes, actually we collected biplane radiography data as well. And so that would be a potential next step, is to analyze that data and look at sagittal plane and frontal plane kinematics. And to kind of tie in one of the other questions, that would also be when we would look at transverse plane kinematics, because there would be less error associated with biplane radiography data.
Excellent, thank you. Any other questions from the audience or ones that I've missed? We do have a clarification regarding Sabreen's question for SPM. To answer that question, we use SPM to analyze differences across the gait cycle rather than choose specific points to analyze differences. So thank you for that clarification, Clarissa. Any other questions at this time? All right, we'll move on to our final section.
Great. Now we have Rebekah Koehn presenting on joint acoustic emissions as a biomarker for knee health assessment in loaded and unloaded exercises.
Thanks for having me. Do you see the slides? Okay, hello everyone. I'm Sevda, a PhD student in ECE at Georgia Tech. I'm going to talk about joint acoustic emissions as a biomarker for knee health assessment and comparing them in loaded and unloaded exercises. This study is supported by National Science Foundation, NSF, and it is based on a protocol approved by Georgia Tech and Emory University IRBs. Here, we targeted children diagnosed with an autoimmune disease called juvenile idiopathic arthritis, or JIA in short. Inflammation of a joint is called arthritis, and idiopathic means that the origin is unknown. Children with JIA form a population of 0.1 million in United States. In half of the cases, it can become a chronic condition and last for several years, affecting the patient's quality of life. Unfortunately, it has a high variability presentation, and there are few reliable biomarkers. Also, there is a limited access to pediatric rheumatologists, which are especially trained for diagnosing and treating JIA, where only 1 in 4 children with JIA can regularly visit a doctor. If left untreated, synovitis and inflammation of a joint can cause damage to the underlying cartilage and bone. Therefore, early diagnosis with effective treatment would be necessary to prevent long-term effects. We focused on knee since it is one of the most commonly affected joint. As you see in the left figure, in a normal knee, the cartilage surfaces at the end of the bones are smooth and slippery, which doesn't make much frictions while moving and passing over one another. But in case of an arthritic knee with inflamed synovial membrane around the knee, gradually these cartilages degenerate and become rough, which creates more frictions and vibrations while moving. Clearly, the vibrations of these abnormal knee structures can be different from normal ones. These vibrations are also commonly known as joint acoustic emissions, or JA in short, or simply joint sounds. To measure joint sounds, several contact microphones, which are basically accelerometers, were placed around the knee. The signals can be recorded with an acquisition system, which you can see a variable acquisition system recently developed in our lab on the right figure. In this study, a dataset of knee acoustic emissions from 38 participants were formed with 2 groups of healthy controls and subjects with JA. These 2 groups are fairly balanced, as you see in the demographics table, and to measure longitudinal changes in the knee, patients had a follow-up recording 3 to 6 months after treatment. Knee sounds were recorded while participants were asked to perform 10 repetitions of 2 exercises. As you see in the right figure, the 2 exercises are unloaded flexion extension while subject is seated on a chair, and loaded squats while the knees are bearing almost the body weight. Below is a pipeline of the signal processing. So basically, JAE signals from 2 exercises were pre-processed by filtering, normalizing, and detection of some of the artifacts. Then the signals were windowed and audio features were extracted, including temporal, spectral, and cepstral features. Then the feature matrix is fed into a soft classifier, and the classifier performance was validated. The output of the classifier would be a knee health score for each subject. Here is the results of the knee health scores, where this score is actually the probability of having JIA. So a score of 0 for healthy subjects and 1 for subjects with JIA. The box plots and distribution of the knee health scores are shown in 3 groups: subjects with JIA pre and post-treatment and healthy controls. Let's compare the scores. First, you can see that the scores of JIA group decrease from JIA pre to JIA post, moving toward healthy subjects with the treatment. This supports clinical records of a successful treatment. The main takeaway is that the scores on average for squats in blue are higher than flexion extension in purple. This implies that loading increases the interjoint friction, which is reflected as the higher scores in loaded squats. Another interesting result is that the difference between squat knee scores and flexion extension scores for JA post-treatment group was statistically significant. In conclusion, the results support the use of joint acoustic emission as an affordable biomarker for knee health assessment in variable system for patients with JA. Also, classification of joint sounds from loaded and unloaded exercises showed that these 2 exercises contain different, possibly clinically relevant information. In future work, more frequent longitudinal data should be measured over longer periods of time to better determine the usage of this biomarker in diagnosing the treatment of JA. Also, a larger population of participants should be considered. Yeah, that's it, and thanks for your attention, and feel free to contact me at sevda@gatech.edu, and I'll be glad to answer your questions at the end.
Great, thank you, Sevda. Next, we have Hope Davis-Wilson speaking on the association between daily steps, moderate to vigorous physical activity, and femoral articular cartilage composition in individuals with anterior cruciate ligament reconstruction.
Great, thank you. And I'd like to thank my co-authors at University of North Carolina, Chapel Hill. Approximately 100,000 individuals undergo anterior cruciate ligament or ACL reconstruction annually to restore proper knee function following an ACL tear. However, 2/3 of these individuals will go on to develop post-traumatic knee osteoarthritis within 2 decades of initial injury. We know that individuals tend to underload their ACL reconstructed limb compared to both their contralateral limb as well as uninjured control limbs 6 months following ACL reconstruction. And underloading of the ACL reconstructed limb persists 1 year post-ACL reconstruction. We think that these alterations in loading contribute to cartilage composition changes that ultimately cause post-traumatic knee osteoarthritis. And although these changes that occur during a single step in gait are small, they become more significant when you consider how many daily steps a person takes or how much physical activity they engage in a day, a week, or a month. So it remains unknown how daily steps and time in moderate to vigorous physical activity influence cartilage composition following ACL reconstruction. The purpose of the current study was to determine associations between daily steps, MBPA, and cartilage composition in individuals following ACL reconstruction. And we hypothesized that individuals who engaged in greater daily steps and greater time spent in moderate to vigorous physical activity would demonstrate better cartilage composition. So 26 individuals between 6 and 12 months following a primary unilateral ACL reconstruction or hip-mounted physical activity monitors for 1 week to capture average daily steps and time spent in moderate to vigorous physical activity. And we measured cartilage composition using T1-row MRI relaxation times. We manually segmented the articular cartilage into 6 sections, anterior, central, and posterior medial femoral condyles, and anterior, central, and posterior lateral femoral condyles. And we calculated relaxation times as an interlimb ratio, comparing the ACL reconstructed relaxation time compared to the contralateral limb. So a greater interlimb ratio is indicative of lesser proteoglycan content or worse cartilage composition. And we conducted separate univariate linear regressions with either daily steps or time in moderate to vigorous physical activity as the predictor variable and T1-row MRI interlimb ratio as the criterion variable. Contrary to our hypothesis, we found that within the entire cohort, individuals who spent greater time in moderate to vigorous physical activity demonstrated worse T1-row MRI interlimb ratios, specifically in the central lateral femoral condyle. We think that this negative association may have occurred specifically in the lateral femoral condyle because that is where you're most likely to experience a traumatic bone marrow-like edema lesion during your ACL injury. So we think that perhaps if you have that bone bruise at the time of the ACL injury or potentially worse ACL injury, that location in particular may be susceptible to a negative compositional change. As a post hoc analysis, I stratified the cohort into males and females and conducted similar analyses. And we found that males who engaged in greater daily steps and time in moderate to vigorous physical activity demonstrated worse T1-row interlimb ratios, specifically in the medial femoral condyle and the anterior lateral femoral condyle. Conversely, we saw that females who engaged in greater daily steps actually demonstrated better T1-row interlimb ratios, specifically in the central and posterior medial femoral condyles. So why would males and females have opposite associations between physical activity and cartilage composition? Some hypotheses are that males are more likely to have a contact ACL injury and potentially experience worse cartilage damage during the initial ACL injury. And that can make them more susceptible to negative cartilage compositional changes in terms of loading the joint. Our males also had higher mass compared to females, and we're still a little unsure of how mass influences loading at the knee joint following an injury. Lastly, our males also engaged in higher amounts of moderate to vigorous physical activity compared to our females, completing almost 70 minutes of moderate to vigorous physical activity every day. Our males were about 9 months post-ACL reconstruction, and it could be that 70 minutes is just a lot of physical activity for a person that early following their injury. In conclusion, daily steps and moderate to vigorous physical activity associated with cartilage composition, but the direction of the association was dependent on whether you were a male or a female. So evaluating sex could be an important factor to consider when looking at daily steps and moderate to vigorous physical activity following an ACL injury. And we think that other characteristics such as the mechanism of injury, mass, amount of physical activity could also influence this relationship between daily steps, moderate to vigorous physical activity, and cartilage composition. And I'd like to thank my funding source, and I'd love to hear from you if you have any ideas about moving forward with this research line. Thank you.
Fantastic, thank you, Hope. Next, we have a video from Nathan Shalati titled Linear Discriminant Analysis Predicts Knee Injury Outcome from Biomechanical Variables.
I'm excited to discuss with you how linear discriminant analysis predicts knee injury outcome from biomechanical variables. The anterior cruciate ligament, medial collateral ligament, and the menisci are the most commonly damaged structures of the knee. And these injuries, although they can occur in an isolated or a concomitant fashion, are likely driven by specific mechanics versus random coincidence. Continued evidence supports that knee abduction moment strongly contributes to non-contact ACL injury, and the non-contact mechanism accounts for 70 to 80% of these events. Our team has developed a mechanical impact simulator that can reproduce ACL injuries with approximately 90% success rate based on drop vertical jump in vivo input parameters. The hypothesis of this study was that linear discriminant analysis will distinguish different knee injury presentations from biomechanical and demographic variables with high specificity and sensitivity. With this study, we acquired 41 unembalmed, fresh frozen cadaveric lower limbs with the inclusion criteria of age 18 to 50 and the absence of lower extremity injury in their health record. We prepared the specimens by sectioning them at the mid-femoral diaphysis, 20 centimeters above the knee joint line, and then we took the quadricep and hamstring tendons and isolated them and put clamps on them for muscle load simulation. Remaining musculature in the skin were left intact for realistic load transfer. And we had an orthopedic exam performed by a board-certified orthopedic surgeon. We then instrumented the knees with DVRTs, which are strain gauges, on both the ACL and the MCL, utilized a 6-degree of freedom load cell to measure the forces and torques at the knee joint, as well as a uniaxial load cell that would record the impulse force delivered at the foot. We then placed the specimen inverted into the rig that you see here, with the tibial fixture attached for external load application, which you can see here. And the knee was placed at a 25-degree knee flexion angle, which is a common angle of knee landing. And then we attached the muscle and external load cables with a 1-to-1 ratio for the quadricep and hamstring ratio. We had a subfailure protocol in which 46 randomized tests were performed with a random selection of the knee abduction moment, anterior shear, and internal tibial rotation loads, which you can see on the table above. And the drop sled was standardized at 75 pounds from a 12-inch height or 31 centimeters. In a failure protocol, if the specimen survived all of those previous randomized tests, started out at the 100% rate for each of the 3 parameters, knee abduction, anterior shear, and internal tibial rotation, and the drop sled was placed at half of the specimen's body weight. And then testing would continue with 20% incremental increases until either soft or hard tissue failure occurred. Here's a demonstration of our rig at work. You can see the mechanical impact simulator delivering the impact, simulating the drop, and you can see the torsions placed on the knee. The subjects overall had an average age of 41.5, a mass of 85.7 kilograms, and a height of 173 centimeters with a BMI of 28. And on the table on the right, you can see the injury classifications that we had of the 41 specimens with ACL, MCL, and meniscal damage represented. We then put these parameters into a bootstrap forest partition model and pulled out the 5 factors, 10 factors, and 15 factors that were most likely to contribute to the injury. We then performed the linear discriminant analysis, and this demonstrates the confusion matrix at the top, as well as the ROC curves for each of the injuries. For the 5-factor model, misclassifying 38%, the 10-factor model, misclassifying 18%, and then the 15-factor model, misclassifying 6%. In summary, knee injury outcomes are not coincidence, but rather they are driven by specific injury mechanics, and they can predict knee injury outcome with high confidence. This LDA classification paradigm is an important step to future machine learning algorithms that can rapidly assess complex and covariate data and determine specific risk of musculoskeletal injury. Thank you so much for listening.
I should mention that Nathan is with us today, so he will be able to answer your questions at the end of this session. So please drop your questions into the Zoom chat window. Next, we have Melissa Boswell presenting mindsets are related to reductions in pain after a gait modification intervention for people with osteoarthritis. Melissa, you're currently muted.
Okay, got it. Sorry about that. Okay, so my name is Melissa, and oh, I don't want to leave the meeting. And I'm excited to share some of my work on how mindsets are related to outcomes after a gait modification, and more broadly, how we can leverage psychology to improve the efficacy of and adherence to biomechanical interventions. So first, I want to introduce the psychological construct mindset. Mindsets are core assumptions about the nature of things and processes in the world that orient people to a particular set of attributions, expectations, and goals. Mindsets influence what we pay attention to. They influence our affects, our positive or negative emotions, our behavior, and our physiology. So you might be familiar with mindsets about intelligence, well known as fixed or growth mindsets, but more recently, researchers have been studying mindsets about health. For example, one study found that informing hotel housekeepers that the activities they performed at their daily job satisfied recommendations for a healthy lifestyle led to higher levels of perceived exercise, as well as weight loss and a reduction in blood pressure, even without an increase in objective physical activity level. The relationship between mindsets and biomechanical interventions is unknown, but this study presents a first step towards understanding this relationship so that we can start to understand how they influence each other and how they both influence health. In this study, I measured the mindsets of people with knee osteoarthritis in a gait retraining intervention. 26 individuals with radiographic knee osteoarthritis completed 1 year of personalized foot progression angle gait retraining to reduce the knee loading. We calculated the reduction in pain as the difference in the 10-point numerical rating score between the beginning and the end of the study. At the end of the study, participants' mindsets about illness were assessed with the Illness Mindset Inventory Summary Score. We calculated Pearson's correlation coefficient between these two variables. The Illness Mindset Summary Score is a composite score of 6 questions, part of a larger and validated mindset survey. It is scored from a 1 to a 6, where a 1 signifies a less adaptive mindset about illness, and a 6 is more adaptive. In the case of a less adaptive mindset, someone might be thinking, osteoarthritis has ruined my life, it is only going to get worse and it's out of my control. On the other hand, a more adaptive mindset might be associated with thoughts like, osteoarthritis may be challenging at times, but there are things that I can do to improve my symptoms and still live an active and fulfilling life. While these are not direct quotes, they do summarize the words and language that individuals with osteoarthritis use when I ask them how osteoarthritis has influenced their lives. Now I will present the results of the study. So here's a scatter plot of the change in pain over the course of the intervention versus the illness mindset score. You can see that a higher change in pain, so a larger reduction in pain, is correlated with a higher or more adaptive illness mindset. And this is consistent even when controlling for whether the person was in the intervention or the control group. I also want to show the results of another survey study in individuals with osteoarthritis, where we asked how they managed their osteoarthritis symptoms in an open-ended question and measured their mindsets about the process of being physically active. So this captures how much they enjoy or dislike being physically active. This is a plot of the measured process of exercise mindset on the y-axis, where again, a higher score is more adaptive. And on the x-axis are 3 different responses for how people manage their osteoarthritis. So on the left is with pain medications or injections without exercise. In the center is with both medication and exercise. And on the right side is with exercise but without medication. And you can see that those who manage the disease with exercise have a much more adaptive mindset about exercise than those who use pain medications or injections. And it's also interesting to note that there is no difference in mindset between those that use exercise with and those that use exercise without medication or injections. So what are the takeaways from these studies? In these studies, I found that mindsets are related to outcomes of biomechanical interventions and an individual's chosen management strategy. But it's important to note that these studies are cross-sectional, and future studies should be longitudinal to evaluate causation and use more objective measures of physical activity and function. As biomechanists, we should be aware that what we are saying and what we are doing influence mindsets, and try not to shift mindsets throughout our studies. It's particularly important not to have a negative impact, because this can lead to negative health consequences downstream beyond the study. So we can be aware of situations where this might occur, like if an individual's pain or function doesn't improve, we can mention that there may be other management strategies that could help, or help them recognize the other positive impacts of the study, such as getting more exercise. On the other hand, and more positively, improving mindsets may increase the efficacy of outcomes of technologies and interventions that we develop. And we can leverage mindsets and more broadly psychology to help people reap the most benefit from movement. So thank you to my co-authors and collaborators and the support of the Neuromuscular Biomechanics Lab and the Mind and Body Lab. And thank you for listening. I'm happy to answer any questions, and please feel free to reach out with additional questions, comments, or opportunities for collaboration.
Excellent. That was a great group of talks from our speakers. Thank you so much. Let's jump into the Q&A. And we will start. Oops. All right. So we have one for Savita. Great work from Stephanie Koehn. What was the severity of JIA symptoms or the length of time since initial onset of symptoms related to the JAE score in the pre-op group?
So you asked a great question. Thanks, Stephanie. So the severity of JA, we have some clinical records over that, but we haven't applied it with our analysis yet. But that's a future work, I assume.
Thank you. Great. Next, I had a question for Hope. Great presentation. Can you describe your T1-row MRI methodologies in greater detail? For example, how long following load was imaging conducted? What was the resolution of your scans? And did you perform any reliability analyses of the manual cartilage segmentation?
Thanks. Yeah, so we had individuals in a resting position with their knees straight for 45 minutes prior to the MRI. They always started with their contralateral limb, and then we did the ACL reconstructed limb second. I'm not sure of the resolution off the top of my head, but we do perform reliability analyses for the manual segmentation from study to study. And I was the only manual segmenter for these 26 participants, which made it a little simpler, but I had been deemed reliable compared to other segmenters. Yeah.
Excellent, thank you. Next, we have a question for Nathan from Stephanie. Nathan, that was great. You mentioned setting the quad hamstring ratio at 1:1. I'm wondering if you have or plan to look at different ratios as an injury risk factor.
Yeah, it's a great question. Initially in this study, we were wanting to just determine whether the external loads, which one was the greater contributor to ACL injury risk. So we didn't want to really parse much out with the quad and hamstring ratio, but it is something that we can modulate and change and is of interest of us. And as soon as we get future funding, we'll go for it.
Awesome. Next question is for Melissa from Abby Neeson. Did you look at how stage of OA might have impacted the results? What were the grades of OA for the subjects?
Yeah, so I didn't include that as a control variable. I did include their change in the adduction moment and also saw that there was a change in pain between the intervention and control group, but I didn't look at their stages of OA, but I think that would be a great thing to include in the future.
Great, thank you. Oh, anything else?
I was just going to say, because somebody else also asked about like psychological parameters and other things that we could control for. And I didn't do that in this study because there are so few people, but in another study of 150 people, we looked at how mindsets predict future physical activity level, and we controlled for how long they've had osteoarthritis and demographics, and also psychological variables, including pain catastrophizing and fear of movement, and self-efficacy of exercise. And mindsets predicted future physical activity above all of those variables.
Excellent, thank you. Our next question is for Savita. Nice work. Do you have any plan to test the knee OA patients using the same technique?
Great question. Actually, one of our team members is working on osteoarthritis patients for quantifying them with joint sounds, and we are currently collecting the data for those patients.
Excellent, thanks. Our next question is for Hope from Fran Sheehan. Were you able to evaluate the presence and intensity of bone bruising post-ACL tear in your patients?
We haven't done an analysis saying like, oh, there was a bone bruise, there was not a bone bruise. With T1 row, it's highly correlated with the amount of proteoglycan in the area. And so we typically do notice that that central lateral femoral condyle does have lesser proteoglycan content. And so it's something that we have wondered if that is related to the bone bruise. And I think it's something we'd be interested in moving forward to evaluate more firmly.
Excellent, thanks. Next question is for Nathan from Jared. Can you explain the low occurrence of meniscal tears in your model relative to clinical cases?
Yeah, so with that mechanical impact simulator, we are applying external loads, which obviously is not occurring with an in vivo population. And at some point during that simulation, it's potential that it can actually restrict the knee motion slightly as the cables are pulling back and forth on either side. That's a potential mechanism that could explain the difference, but also depending on the study that you reference, depends on whether or not we're in range or out of range. So, hard to say exactly whether or not it's out of range, but it is something that is a limitation in the model, potentially based on that movement, but we know that it is actually creating the ACL injury 90% of the time with a pretty clinical presentation of concomitant injury. And the great thing as well is the orthopedic surgeons that examine the knees afterwards are stoked at how it looks very similar to what they see in the clinic. So that's encouraging.
Great, thank you. Another question for Melissa from Anita. It's great to see more people integrating biomechanics and psychology. Did you consider any other psychological measures such as mindfulness, stress, or affect? Also, was mindset related to any of the biomechanical changes?
Yeah, so again, in the study, since it was a smaller subset of people, I didn't include any other psychological measures, but I did do that in a previous study. I didn't look to see if it was related to biomechanical measures. I just controlled for the change in the knee adduction moment to see if mindsets were still related to changes in pain above that. But I think in future studies, it would be really cool to look at how mindsets are related to biomechanical parameters.
Great, thanks. Another question for Savita from Jared. Exciting work. As JIA is first diagnosed by pain, can you please can you continue work establishing the relationship between joint acoustics and changes in joint morphology?
Interesting question. It would be nice to find a relation between the score that we get from joint sounds with the pain, but I'll guess that it would be difficult because it's a subjective parameter for each patient, and the answers to that question would be quantitatively different for each patient, but would be interesting to find out.
Great, thank you. Next question is for Hope from Alexa. Great job, this is interesting. Did you happen to have articular cartilage health and/or rating at the time of surgery? How do you think this may affect T1 row cartilage composition or asymmetry later on when you tested them?
Yeah, we don't have baseline MRI, but we do have surgical notes, so we can get an idea of chondral or meniscal damage that was present at the time of the reconstruction. And I think moving forward, based on my 26 participants, it would definitely be worthwhile to include it as a sensitivity analysis and take it from there to see if it's important, and then whether or not it's a good idea to incorporate it into the statistical analysis.
Perfect, thank you. And then I think we'll do one last question for Melissa. Great talk. Is the mindset survey publicly available? I think this will really be helpful, a helpful parameter for clinical studies. Thanks.
Yeah, thanks. I agree. I think it will also be a great parameter to include in clinical studies. It's not publicly available right now because the mindset measures are fairly new and being validated, and those validation papers are coming out within this year. So hopefully they'll be available after that. But I'd be happy to share those with anyone who wants to include them in a study. I think that would be really exciting. So I'm happy to send those to you.
Great, thanks. So I just want to remind everyone that if we didn't get to all of your questions, they will be copied over into the specific channel in Slack for this session. And I encourage all of the presenters to go look at that and create offline discussions. And if there were questions that you didn't include here, please include them in the Slack too, so that these great scientific discussions can continue. All right, well, thanks everyone for attending this Orthopedic 1 session. I think it was a great success and all of the speakers presented really fascinating work here. So the Slack channel for everyone again is in the chat window. And so thank you very much. If you have any questions, reach out to all of the presenters.